In this video, we'll talk about a big topic that is atherosclerosis, angina, and myocardial infarction. So all together, what we call them? We call them as ischemic heart disease. Ischemic heart disease. So this is understand this thing. Atherosclerosis is a pathological term, and reversible clinical form is called angina. And when it becomes irreversible, we call this MI. Now, what they ask you atherosclerosis is a pathological term, and reversible clinical form is called angina. And when it becomes irreversible, we call this MI. Now, what they ask you pathogenesis and what are the risk factors and how you will see enzyme will increase and what are the ECG changes. So we'll talk about all these changes. So starting with the risk factor. So risk factor we can divide into three categories. One is called modifiable risk factor. Modifiable means which we can modify. Second is a non-modifiable risk factor. Non-modifiable means which you cannot change. And third is a partial modifiable risk factor. A partial modifiable risk factor. So the understand this thing. Modifiable means what we can change. So what are risk factors? The first modifiable risk factor is habit of smoking. So smoking we can modify by nicotine replacement therapy like nicotine gums, patch. Then we have certain drugs like varenicline, bupropion. Similarly, second is alcohol. And alcohol risk we can terminate by using a drug called disulfiram. Then I can say third modifiable risk factor is your sedentary lifestyle. And how we can modify this? By increasing your activity. Sedentary lifestyle means you are just eating, sleeping, and repeating. So this we can modify by doing like cardiac activity or any type of jogging, running, right? And fourth is something what we call this our diet. Suppose if you are taking a high fat, high carbs in diet, so that you can modify by consuming a low carbs, a high protein diet. So these are four things which we can modify. So smoking, drinking means alcohol. Then I can say a patient who's having sedentary lifestyle and diet. So these are four things which we can change. And non-modifiable means remember something which we cannot change. So just remember in ischemic heart disease, risk is something which increase with age. And age we cannot change. So just remember age is not just a number. Age itself is a risk factor. With age, you will see there is more sclerosis in the blood vessels. Then remember second is your gender. Even nowadays we can change the gender, but again changing gender in that way will not alter the risk. So just remember gender wise I can say if you ask me male is to female ratio in young patient, it is 2:1. Means males are twice affected compared to females. So there are multiple reasons because in India, if you see like male travel more, male are like mostly working outside, so male drink more, male smoke more, and males they don't have estrogen. Very important. What estrogen will do? Estrogen will increase your HDL level, and HDL is something what we call HDL is called good cholesterol. But remember after menopause, when female is not having estrogen, then this risk become means in old people if you see the risk will become 1:1. So gender is something. Then third I can say third modifier means that is family history. Means suppose if your both parents are having atherosclerosis or one parent is having, you are also having a risk. So family history is something which we cannot change. Now next is partial modifiable means which we can modify to some extent. So this is an autosomal recessive condition and we call this homocystinemia. Homocystinemia, or we can call this homocystinuria. So it is an autosomal recessive disorder. If you avoid a diet which is having homocysteine, then you are protected. But if you continue to take a normal diet, then you are at risk. So they ask you question, all are modifiable risk factor except, all except type of question. Now they ask you what is the pathogenesis, means how we can understand the pathogenesis of disease. So when it comes to pathogenesis, so just understand this thing. Suppose for this I will make a lumen of a blood vessel. Suppose there's an artery. So inside this artery, understand this thing, what you will notice. You start smoking, drinking at the age of I can say 17, 80 years, means 18 years, means in around your teenage. So when you do this for 5-10 years, what will happen? First thing you will notice this endothelial will injure. So very first step will be endothelial injury. So first thing what we see is this endothelium is ruptured. And when endothelium is ruptured, understand, from this ruptured area, a low density lipoprotein, that is your LDL, this will enter inside your blood vessels. So you will notice second thing will be LDL enter. When LDL enter, understand this thing, to LDL, it's a foreign body for a blood vessels. To grab this LDL, remember now it's a chronic process. So chronic inflammation, what are the main cells? We have macrophage. So macrophage will enter. So now you can see macrophage will enter. So LDL enter and macrophage enter, MS macrophage. So now you can see both LDL and macrophage, they are inside the blood vessel. So LDL will change its shape. So LDL will change its shape, and this LDL will now convert into OLDL. O meaning is oxidized LDL. So it is now oxidized LDL. So this oxidized LDL is not being identified by macrophage for many months, maybe many years. But when they identify this, you can see there will be a fight between LDL and macrophage, and what we get? We get a structure. This structure is what we call, it's a loose structure. Here you will see, we call this foam cells. So here we have foam cells, and this structure is what we call this fatty streak. Fatty streak. So they ask you what is the first step in ischemic heart disease. So answer is endothelial injury. Not an exam question. And if you ask me like what is first gross evidence, it is your fatty streak. So fatty streak is having foam cells, and what is inside the cell? Here you will have lipid, laden, macrophage. Inside this you will see lipid, laden, macrophage. So these are inside where? Inside this fatty streak. Lipid, laden means lipid and macrophage. So this is what we call this fatty streak. But the good thing about this fatty streak is, this fatty streak means, suppose you started smoking and drinking at the age of 17. So by the age of 30, 35, you will develop this fatty streak. So this is something which is reversible. And how it is reversible? It is reversible when you change your diet, when you change your habit, right? Because when you can modify this factor. But what happens with stress as your age advances? What happens if you see like now people become daily wages alcoholic, means they are drinking now alcohol daily, they are smoking daily because of their busy schedule, they are not going to gym. So slowly you will notice this was the fatty streak. Inside this fatty streak, it was lipid, laden, macrophage, and you will notice there will be a type of necrosis. So this necrosis is what we call this coagulative necrosis. This necrosis is what we call this coagulative necrosis. So they ask you which necrosis occur in heart. It is coagulative necrosis. And you will notice like fibrin will deposit on the top. Fibrin will deposit on the top of this fatty streak. So you can see this is fibrin depositing here. And when fibrin deposit here, what we call this? So you can notice this is fibrin depositing. So it deposits on the top like a cap. So this is what we call this capping. Capping. And then fibrin can also deposit on the sides, on the edges. So fibrin can also deposit on the sides. So this is what we call this shouldering. So understand this thing, fatty streak was something which was reversible, but now there is a three-step process. This is called capping, shouldering, and inside, because of this necrosis, you will call this as necrotic core. So this is something which is now the same fatty streak is called as atherosclerotic plaque. So this is what we call this plaque. And this plaque is something which is irreversible. It is something which is irreversible. So understand this thing. First thing what you have seen was fatty streak. Now it is stabilized by three-step process: capping, shouldering, necrotic core. What we call this plaque. And this plaque will give you three surprise. First is maybe sometime you will have chest pain. That chest pain will be called as angina. Sometimes, like suppose along with chest pain, you will see cardiac biomarkers are increased. You will have changes in the ECG. We call this MI. And suppose sometime what happens, you will not get a much warning sign, and patient will immediately die. And what we call this sudden cardiac death. So this plaque or atherosclerotic plaque, this can cause three things: angina, it can cause MI, it can cause sudden cardiac death. So these are the changes which you have to remember. Now try to understand this thing when they ask you like about types of MI. So what are the types of MI? So understand this thing when I ask you about types of MI. So one classification that you study in MSN, that is like based on location of wall, anterior wall, posterior wall, inferior wall. But here I'll tell you, like suppose if you see like all layers of heart are involved, when all layers of heart are involved, that is called transmural. All layer we call it transmural. And remember, in heart we have an area, that area is called a subendocardial. So this subendocardial, this is that area which is least perfused. So this is also an MCQ, like this is the least perfused area. So here you will find least perfusion. So when it involves all layers, we call this transmural. And when all layers are involved, understand this thing, when all layers are involved, what we call, you will see like patient will have ST elevation, and what we call this STEMI, ST elevation MI. And when only subendocardial area is involved, then you will not see as such classical ST elevation. So what we call this non-ST elevation MI. So these are types of MI. Now what they ask you in exam, they ask you like suppose when you see this plaque formation, so there are two types of plaque. So one is called a vulnerable plaque, second is called stable plaque. So what is the meaning of this word vulnerable plaque? Understand this thing. Vulnerable plaque means this plaque will have a thin fibrous cap, right? You will find foam cells and lipid core. So when this fibrous cap is thin, right, this is vulnerable to rupture and it will attract more and more platelets. So there is more chance of forming a bigger clot later on. So this is something which is vulnerable, means it is something which is more dangerous, means it is vulnerable to rupture. Second, you will see like a stable plaque. Stable plaque means, understand this thing. Stable plaque is something where you will see this fibrous cap is now thick. So it is not easily going to rupture. This is something which is stable. So they ask you like out of these two plaque, which plaque is dangerous? So just remember how we differentiate vulnerable and a non-vulnerable. Stable plaque is also called as non-vulnerable plaque. Non-vulnerable plaque. So we can differentiate this by fibrous cap. So fibrous cap is thick where in stable plaque. Then what they ask you, suppose a patient who is having MI. So what are the sign and symptoms you will see? Suppose clinical feature of MI. So these patients, understand, they will have chest pain. This chest pain is what we call this angina. So there will be chest pain, angina, and this chest pain is typically radiating to your left shoulder, left arm, left side of neck, sometimes back area. So this is like a left-sided chest pain, radiating to back, neck, to arm. So sometimes what happens, you will notice like patient will compress the chest with the dominant hand, like this he will compress. And this sign is called as Levine sign. So what is Levine sign? Understand this thing. Levine sign is patient will compress the chest with dominant hand. Now, some people, if you notice, like they will not have this angina, then what they can have? So what do we call this? Some people like because of neuropathy or those who are very fatty people, those who have a lot of obesity, they will not sense the pain. So then they can have like unexplained shortness of breath. Means patient is a non-smoker, his lungs are clear, but he's having shortness of breath. Then I can say unexplained sweating. Unexplained sweating means we also call this as diaphoresis. Means it's like a month of January or December, it's a winter, AC is on, or I can say AC is on, but patient still sweating. We call this unexplained sweating. Then fourth, what I can say, it is like something unexplained sense of impending doom. Sense of impending doom means, now what is the meaning of this thing? Patient will have a fear and he is just telling you, please save me. I'm having kids, I'm having my wife, I'm having my family. Like the sense of a sense like God is calling. So that a call from the God he is feeling. That's called sense of impending doom. So these are the symptoms, and these symptoms, just remember, these symptoms are considered equal to angina. We call them angina equivalent. Now they ask you, suppose if you are having this type of features, then what is the first test? The first test you will do is an ECG, and they ask you what are the changes which we see in ECG. So in ECG you will see four changes. First is you will see hyperacute T wave. Hyperacute T wave. This hyperacute T wave generally occur because of potassium leak. Then suppose if it is like transmural, then you can see ST elevation. But if it is like, I can say, not involving all the layers, then you will see some changes where in ST segment and T wave. So you can see ST segment and T wave changes. In STEMI, ST elevation, MI, you will see ST elevation. Then third thing what I can say is like patient will have a deep Q wave, a bigger Q wave. So see, suppose if I make this is P wave, then we have QRST. But here you will see this is P wave. Then you can see a deep and this type of deep Q wave, means you can notice here this Q wave is a little, but this Q wave is bigger. So you can notice patient will have a deep Q wave, or we call this as pathological Q wave. We call this deep Q or capital Q or pathological Q wave. Pathological Q wave. And later on you will notice like this ST segment will return to normal. So lastly you will see ST segment will become normal. So they ask you what is the earliest change. So earliest change, remember, it is not ST elevation. Earliest is hyperacute T wave. Very, very important. Now suppose after ECG the next test will be cardiac markers. So you will do markers. So in markers, what are the markers you will check? So we have different markers. So first try to understand this thing. Suppose if you see markers are elevated or markers are normal. So understand this thing. If markers are elevated, then it is MI. If markers are normal, then it is not MI, it is angina. So just try to understand this thing. Similar ECG changes you can also see in angina. So we cannot differentiate angina and MI based on ECG. We can only differentiate this based on markers. If markers are elevated, then it is definitely going to be your MI. So what are these markers? Understand this thing. These markers, a sequence you can remember by mnemonic: high, my, the, castle. high Maida castle. High Maida castle means it's a new update which you have to remember. High is heart specific fatty acid binding protein. So this is H. Then we have I. I stand for IMA. IMA is ischemia modified albumin. So these are two new markers: heart specific fatty acid binding protein, ischemia modified albumin. And what I can say again, they have not asked this question, but they can ask in future. This is the earliest marker. But why they are not asking? Because these are not available in India. So what they still ask you earliest. After this, earliest is myoglobin. So when they are not given in the option, then what you have to choose? Myoglobin. Myoglobin. Now coming to the T stand for troponin. It is troponin. In troponin, we have two fragments, troponin T and troponin I. Right? So they ask you like, what is a better form? So understand this thing. Always tell yourself, I am the best. So remember, troponin I is something which is the best form. And troponin T, this is, I can say, most common used test. Why? Because it is available in a rapid kit form. It's available as a rapid diagnostic kit. Right? So it's available. You can see, you have seen this pair in your emergency department in casualty. Then what we have C. C stands for CPK. So CPK is having different form. So the form that we use in cardiology is CPK-MB. So we have different forms, but the form that we use in heart disease is CPK-MB. AST stands for AST. AST stands for AST. So AST is AST. Simple. AST means, I think we have discussed this AST here in your liver disease. It is a specific marker for alcohol-induced liver disease. And last L stands for LDH. So the sequence you have to remember, high Maida castle. So let's understand this thing. What is the markers which are having practical importance? So let's say, if you ask me, heart specific fatty acid binding protein. So these are something which are not available in India. So I'm putting a cross on this. So we don't use this in practice. Myoglobin is something which is not specific. Not specific means you can see, suppose if this a roof is falling down on me, then, or I can say a car is moving across my hands or legs, then my skeletal muscle will damage. So that can also release myoglobin. That's called myoglobinuria or rhabdomyolysis. So myoglobin can be released in muscle injury. So again, it's non-specific. Then AST is also increased in alcoholic liver disease. Even in other liver disease also it can increase. And LDH can be increased where? LDH can be increased in your, I can say, hemolytic anemia. When RBCs are breaking down, LDH will come out of the RBCs. So these are non-specific. So in practice, we are left with two things, and those two things are troponin and CPK-MB. So if you ask me what is the best marker, so just remember the best is troponin, and in troponin, which is the best? In troponin I is the best. Then understand this thing, CPK-MB. CPK-MB is used for reinfarction. But also there's a new update here. This question came in medical entrance, not in nursing entrance. Like for reinfarction, just remember, if you check troponin every 1 to 2 hours, that's what we call serial troponin. So serial troponin, it is a better test than CPK-MB. Is clear? Serial troponin measurement for reinfarction also. But sometimes if they ask you an old MCQ for serial means every 1 to 2 hours. For old reinfarction, what is the best test? If options are given like myoglobin, CPK-MB, then you have to choose CPK-MB. But if serial word is given, then choose that answer. So these are the markers which they sometimes ask in exam. Now what they ask you like this graph sometime in exam. So let's say this graph. So this is like graph in days. So first markers you can see like myoglobin is not given because that is not routinely used in practice. You can see first markers which you can see like we have CPK-MB and troponin. So if you see this line, of troponin line, just I'm highlighting this line. You can see this troponin is increased in the body for so many days. Means like you can notice they ask you in exam, troponin, it start in 4 to 6 hours. It peaks at 12 hours and it is like in your body till 7 days. So you can see it is up to 10 days, sorry, it's up to 10 days it can be. So that is why it is considered the best marker. Similarly, if you see CPK-MB, it start along with troponin, peaks at 12 to 24 hours, but it return by 70 to 96 hours, means in 4 days, it will be normalized. So just look at the CPK-MB. Now, if you see like this SGOT is same, AST. And what we have LDH. So these are not used. So in practice, what they ask you again, nobody will ask you about myoglobin. What question they can ask you is just CPK-MB and troponin. Because myoglobin is increased slightly before. And even if you see, like I told you, heart specific fatty acid binding protein, and ischemia modified albumin. So these, to understand this thing, they will increase even in 1 to 2 hours before myoglobin. but again they are not routinely used in our country, so they are not being asked. What they ask you, CPK, ambient, troponin, so each and every line is important. Okay, one more thing I'll tell you like about LDH. So if you are not routinely sequence, they ask you what is the last enzyme to increase. So last enzyme to increase, that will be your LDH. So LDH is also called as last enzyme or lazy enzyme. Last enzyme or lazy enzyme. Then remember normally what happens. So normally you will see LDH2 value is more than LDH1. But in MI what happens? LDH1 value will be slightly more than LDH2. So nothing happened, just 2 is 2, 1, 1, 2. So that's 2, 1, 1, 2 means that is called flipping. So this question came once, flipping of LDH. So understand, flipping of LDH, it is seen where? It is seen in MI. So they ask you flipping means LDH flipped from 1 to 2. It is something which we seen in MI. So they ask you this graph sometime like, so just remember about troponin and CPKMB. So remember troponin will increase in your body. It start rising by 4 to 6 hours and it remain up to 10 days. And if you see CPKMB, it start with troponin like 4 to 8 hours and it remain till 3 to 4 days. So this is about your cardiac markers which they routinely ask in exam. Now what they ask you like suppose if a person who is having MI or myocardial infarction. Now what are the changes? Means what are the microscopic changes? So what are the pathological changes you will see? And these changes we can divide into category like based on time, changes in time. Then these changes I can say what are the gross change, what are the gross change. Then they can ask you what are the light microscopic change and what are the electron microscopic change, right? So now understand this thing. Electron microscopic is more magnified image, so you will find something there. So let's understand this. If you remember chapter 1 cell injury, right? So here we need to recall that changes. So starting with the first thing, suppose if you ask me like what happened in initially 1 hour, means suppose 0 to 1 hour, 0 to 1 hour, you will see there will be no change. There will be no change grossly. So there will be no change means none, no gross change, and even no change in light microscopy. No change. But in electron microscopy, you will find something. So now see, initially when person's having MI, so initially it is always a reversible cell injury. So what is the hallmark feature? What is the hallmark feature of reversible cell injury if you remember? What is the main feature? Cell swelling. Yes, so you will see cell swelling. You will see cell swelling and even the organelle inside the cell will swell. So you can see cell swelling or I can say mitochondrial swelling, right? Is clear? Now try to understand this thing. You will see mitochondrial swelling, cell swelling. There will be loss of glycogen. So these are the changes. Just remember cell swelling, mitochondrial swelling. Now coming to next change. Suppose if you ask me what will happen in suppose initial 2 to 4 hours, or better term is 1 to 4 hours. 1 to 4 hours, what will happen? Okay, so understand. In 1 to 4 hours, you will see again. So grossly there will be no change, no change. But in light microscopy, you will see like the fibers will become little wavy. We call this waviness of fiber. Waviness of fibers. So waviness of fibers you will see where in light microscopy. Now understand this thing. After 1 hour, or in some people after 2 hours, you will see the reversible injury will convert into irreversible. So now tell me, in irreversible, what are the electron microscopic change? Just remember, go with chapter 1, think of cell injury, what we have studied. In irreversible cell injury, you will see something will deposit in the mitochondria. Anybody remember what we call? These deposits are called amorphous densities. Yes, very good. You will find amorphous densities. So these are the amorphous densities which will deposit in the mitochondria. So this will be seen where? Throughout, means after 4 hours, because MI is irreversible. So you will find in electron microscopy amorphous densities. Now what they ask you, suppose they ask you, like, suppose after 4 hours, I can say third change. So 4 to 12 hours, what changes you will notice? So 4 to 12 hours, or you will notice there will be like mottling in the heart, that is a dark mottling, that is due to necrosis. So you will see a dark mottling, and this dark mottling occurs because of necrosis. Now tell me which type of necrosis. Yes, this necrosis is coagulative necrosis, but to see it is coagulative or not, you will need to do electron microscopy. So you can see there will be coagulative necrosis. Now understand this thing. When you see coagulative necrosis, along with you will see some eosinophils will increase. That's called hypereosinophilia. Hypereosinophilia. And with this you will notice neutrophilic infiltrate. So first cells will be neutrophils. So these are the changes where you will see in 4 to 12 hours. Now suppose it's been 12 hours. After this, means it's been 1 day. Then what you will see? So in 1 to 3 days, means suppose after 12 hours, or I can say in 12 to 24 hours first 12 to 24 hours. 12 to 24 hours. Now see, this was a mottling. Suppose this was a mottling. Inside the mottling, you will see a tan color. Just let me just make it clear. You will see inside the mottling, you will see a yellow or tan color. Inside the mottling, what you will see a yellow tan softening. So I can say this is what we can say dark mottling with a yellow tan in yellow or tan, I can say center of infarct, yellow tan area in mottling. So these are the changes that we see. Then understand this thing. You will notice, like, again, this changes will continue. You will see same changes, coagulative necrosis. You will see neutrophils infiltrate. In fact, it will now increase. It will be more than previous. Now coming to 12 to 24 hours. After 12 to 24 hours, I can say in 1 to 2 days, what will happen? So understand this thing. You will notice this process will continue. Means next 3-4 days it will continue. So I can say in 1 to 3 days. 1 to 3 days, the same thing will continue. This will continue. The cellular softening will enlarge in size. Even you will notice, like I can say, this coagulation necrosis will continue. Then what else they ask you? They ask you what will be the changes. You will see after that. After that means in which day? Now see 3 to 7 days. 3 to 7 days, what you will notice? Now see. Now in 3 to 7 days you will notice, like, there will be same thing. You will see same yellow tan infarct in the mottling area. Along with this you will notice there will be like some hyperemia. Plus you will notice some hyperemia. And understand this thing. In this you will notice, like, in 3 to 7 days now neutrophils are replaced by macrophage. So you will see macrophage infiltrate. You will see macrophage infiltrate. And after 7 days, understand this thing. After 7 days you will notice now healing process will start. So I can say in 7 to 28 days. 7 to 28 days. So let's say once again 7 to 28 days. What you will notice? Now you will notice healing process will start. And in this healing process, what you will notice? So understand this thing. You will notice, like, again, same. You can see this yellow tan area. I can say in gross region. Then you can notice there will be granulation tissues will come. GT is granulation tissue. And then you can say this granulation tissue, they will try to heal the process. There will be collagen accumulation. So this is like a phase where you can see fibrosis and remodeling. You can see now body is healing. But again, these changes are not visible grossly. You can see these changes only in the, I can say, light microscopy. Then remember, after 28 days, in some people it can take even more than sometime 2 months, you will notice there will be scar formation. So grossly you will see scar, and here you will see like a scar with some dense collagen. scar with some dense collagen. So these are the changes which you have to remember. So let's understand this thing again. You don't have to mug it up. Just remember. Try to understand what are the questions they ask in exam. So they ask you earliest change after MI. First question. First question, it is waviness of fiber. Earliest light microscopy changes will be waviness of fiber. Second question not came in exam, but they can ask you in future. That will be what is first gross change? So answer is mottling. This question never came, but it can be asked in future. So these changes you can remember like this. One day. So what is happening up to 1 day? 1 week. So let me just say these are the changes in 1 day. These are the changes in 1 week, and these are the changes in 1 month. So just remember, 1 day waviness mottling. 1 week, what you will notice? You will notice neutrophils are replaced by macrophage, right? And after in 1 month, you will notice there will be healing with scar. Similar changes you will study in stroke patient. The only difference will be in stroke means in brain. So in brain, what will be the difference? Understand this thing. Instead of coagulative necrosis, you will find liquefactive necrosis. And healing will occur similar time, same. Just remember there will be no scar. The healing will occur with glial cell activation. That's called healing with gliosis. So exact same table, same changes we have discussed in stroke in CNS. So just remember in CNS, what's the difference? Liquefactive necrosis and healing with gliosis. That's it. So these are the changes. Now suppose what they ask you like suppose this is a test called TTC test. Triphenyl tetrazolium chloride test. Let me write the full form of this test. Triphenyl tetrazolium chloride test. TTC test. So understand this thing. What you'll do, you will paint the heart with this TTC. Then you will notice these two areas. So what are these two areas? You can notice like this is a brick red area, brick red color, and here you can notice this pale area. This is pale area, or I can say pale yellow area. So understand this thing. When you notice like if you see like suppose a person who's having normal myocardial tissue. If you see this normal myocardial, or I can say viable tissue. So this is viable tissue. It will appear brick red in color. And ischemic area, it will appear pale yellow. This is called TTC test. Now understand, myocardial infarction can have many complications. They can have many complications that you'll study in detail in I can say in MSN part. Just remember, you will notice like sometimes this question they ask in pathology, like what are these cells? Like patient can end up in heart failure. So these cells, what we call them heart failure cells. Heart failure cells. So understand these heart failure cells. These are seen in a patient of heart failure. These are seen in heart failure. These are seen in heart failure, but where? Not in heart, but they are seen in lungs. So these are heart failure cells. They ask you heart failure cells are seen in lungs. And what are these? Understand these are pigmented, or which pigment? Hemosiderin. These are hemosiderin laden macrophage. So these are macrophage. These are macrophage with the pigment, and that pigment is hemosiderin. So they ask you heart failure cells. These are nothing. These are hemosiderin laden macrophage seen in a patient of heart failure. But where we see them? We see them where? In lungs. So this is about your pathogenesis, ECG changes, I can say, then markers and a complication, pathological changes where in a patient of ischemic heart disease. So this is very, very important, especially the part which I'm telling you. This part is extremely important. They ask you an exam about these markers. This is very, very important. The next video will talk about another topic. Thank you so much. Keep working hard. Bye bye.